Hello and welcome back to the Neurotransmitters. I am your host, Dr. Michael Kentris, and today we are going to be talking about neuroimmunology, a scary topic for even many of us in neurology, but I am very happy to have an expert with me today, Dr. Denis Balaban from the Division of Neuroimmunology and Neuroinfectious Diseases from Massachusetts General Hospital and Harvard Medical School. Is it all right if I call you Dennis today?
Yes, absolutely.
Dennis, thank you so much for coming on the show and talking with us about such a fascinating and confusing topic.
Oh, thank you for having me. I always love talking about neuroimmunology, so I relish any opportunity to do so.
Now, as we were talking before we hit record, let's start with the 50,000-foot view. What do we mean when we say neuroimmunology?
Yeah, absolutely. So what we mean is any sort of neurological disorder in which it is caused by a dysfunction of the immune system, leading to the neurological disorder. So if you have, an antibody-mediated disease attacking your peripheral nerves or brain, if you have, T or B cells causing that, if you have a cytokine storm, as you can see in neurotoxicity in the setting of CAR T cells, all of those are under the broad umbrella of neuroimmunology.
Yes, I know one of our favorite things to do in neurology is just tack neuro onto the front of a pre-existing discipline and just make it our own.
Indeed. Exactly.
So, what does the pathway to becoming a neuroimmunologist or a neuroimmunology specialist look like for people who might be kind of looking to explore that, whether they're in neurology residency or medical students or in some other primary residency discipline?
Yeah, absolutely. So I think there's many different paths that people can take. The way I got into neuroimmunology was uh, I had no idea I would be doing this in medical school. My big question was I want to do neurology, right? And internal medicine, gave me some questioning thoughts because I love that detective work, but nothing was ever going to be as fascinating as the brain. So when I went into residency, I thought I was going to do like cognitive behavioral. And then I realized that that was not my cup of tea personally. And I really found that I loved being on the inpatient general neurology service where a lot of our folks with new diagnoses of MS, autoimmune encephalitis, or we don't know what this is yet, but we shall try some steroids and look, they got better. So I really loved treating those patients because I felt like I had to be at my best in order to be able to diagnose them. So that means I had to really, it encouraged me to read up even more than I was. It encouraged me to ask that very specific question that maybe no one else asked to really try to get to the diagnosis, try different examination maneuvers that maybe others have not done. I really thought it was, neurology on steroids, figuratively and literally. And so once I knew that I wanted to be in neuroimmunology, there's a plethora of different fellowships that are available for those interested. And sort of the usual question that residents face is, do I want to be mostly MS? Do I want to be like MS plus a few other neuroimmunological diseases that I know about? Or just like neuroimmunology, the broad gamut, include infectious disease in there? What sort of neuroimmunology do I want to practice? Because historically it's been MS and the other demyelinating disorders, but now people have a bit more options. So that is how, and I decided to go as broad as possible, and I went to the Advanced General Autoimmune Neurology Fellowship at MGH. But there are people who get into neuroimmunology first from a research standpoint. They'll have done a PhD, they'll have, done their research and published quite a bit, and then they realize, no, I actually want to be treating these patients too. And so then they can find their way into a clinical practice through that avenue. So many roads, I would say.
No, that's great to know, because it is one of those things where we see, as the testing and the identification of these different syndromes has evolved, so too has the training pathways that people can take.
Indeed.
So So what does the practice? I know there's a mixture of inpatient and outpatient. So what is the general vibe in the clinic?
Yeah, absolutely. So in clinic, I have a practice and that is, again, broad. I will see patients with all sorts of different things. People in my general neurology practice whom I've diagnosed with MS, and then I bring to my neuroimmuno practice people with autoimmune encephalitis, neurosarcoidosis, vasculitis, stiff person syndrome, you name it. So it runs the gamut. And I also have patients who I'm following where I'm not exactly sure what might be going on quite yet, but they are complicated. And could there be something neuroimmunological going on? Sure. Have I been able to prove that yet? Not really, but I'm keeping an eye on them, and I'm going to be keeping them in my practice in neuroimmuno as a just to get more time with them in my follow-ups because I have a longer follow-up for my neuroimmunology patients depending on their diagnosis or complexity. On the inpatient side, I mean, so many different things that can happen: meningitis, encephalitis, new strokes from a vasculitis, you name it, myelitis. My gosh, I could any itis I could name. So I think the trickiest part when it comes to figuring out is really making the diagnosis and really raising the suspicion of should I be thinking about a neuroimmunological diagnosis in my patient, because most people are going to first see either their primary care doctor or a general neurologist as sort of that first step. And so I'll say that with better knowledge of things like autoimmune encephalitis being more in the zeitgeist, it's less of a problem these days of the diagnostic delay. And in fact, sometimes there is an overdiagnosis of such things as a paper not too long ago was published describing misdiagnoses. But really, the goal, I think, is for the general neurologist, when hearing certain things on the history or seeing certain things on the examination, to raise a flag to say, hey, maybe I should be thinking about a neuroimmunological diagnosis. And the thing with neuroimmunology is it can touch any part of the nervous system, and it can present either acutely, subacutely, chronically. It all depends. So then people wonder, well, how do I put my arms around this? How do I know that this could be neuroimmunological? So that's sort of the purpose of this talk today, I think, of what are ways in which that in my general neurology practice, I can start to have that intuition and suspicion for something neuroimmunological afoot. So much like in making any diagnosis in neurology, onset and pace are of incredible importance, and really diving down to understand how the symptoms unfolded. And this might seem obvious to any neurologist listening, but it can be more fine-tuned than one might think. So, for example, I had seen a patient who presented with a 2-year history of cognitive decline, and they were, they were older than the age of 50, and the family seemed fairly used to things by then, and it was. I think anybody in a very busy setting with distractions coming in, phone calls, etc. Oh, 2-year history, cognitive decline, probably neurodegenerative. We're done. What was helpful is that someone had gotten a brain MRI that had shown that there were these T2 hyperintensities in their temporal lobes, and oh my gosh, this is actually a limbic encephalitis, and if you just went by this, one-liner of 2-year history, you might miss the fact that actually what happened was 2 years ago, within about 3 months, there was this rapid decline, and then they plateaued for the rest of the time.
Mm.
And then we find out, okay, they have hyponatremia. Okay, they have these brief dizziness spells, and lo and behold, it's LGI1. So I think really trying to, when you ask like, well, how long has this been going on? X years. Okay, and like, how did that really evolve? I think that is a key point in some of these. And if there were changes that happen, like when did those changes occur? Really trying to hone in on exactly when those changes occurred, because that gives you a much more accurate picture. Because there are some neuroimmunological diseases that are characterized not by a gradual decline, but by punctuated declines.
Mm-hmm.
So something like a mononeuritis multiplex or multiple mononeuropathies, for example, where it's like, yeah, I had this carpal tunnel, and it was painful, and I'm a little weak, but it's okay. And oh well, and now I have a foot drop, and oh now I have this, and so really understanding, like, is this happening in quick succession, or are these like years apart? Then okay, maybe not, and you should look for something else. But that's why I mentioned like pace onset as like one of the number one things to focus on first. Because that will get you the diagnosis. That's the first step in making a neurological diagnosis, along with localization, of course.
And I think that's a great point, is that a lot of times we, in the specialty clinics, or even just general neurology, being in some places, right, 3-6 months to get in, you wind up where you are seeing them at the tail after the action has happened, so to speak. And it is like you're asking these people to go back to these probably much more stressful times in their memory. And as you said, like someone's made peace with it, as it were. They don't want to go back and think about when things weren't as bad necessarily, right? It's hard to handle those memories sometimes.
So being able to recognize these things and offer a diagnosis and treatment like that can be powerful, because those patients with encephalitis, depending on the type, they can be reversible and treatable, and they can get back a lot of their quality of life, depending, of course.
Of course. And I think you also bring up a really good point. One thing I think there's been a big trend towards over probably a few decades now is this: in medical training, especially at the medical student level, we see a lot of emphasis on open-ended questions. And I find that like the more and more that I learn, you really need to know how to ask a closed-ended question, and what those closed-ended questions need to be is just as important.
Absolutely. I love that you brought that up. And because I think on a first meeting, open-ended questions are great, because that's sort of like, if information were fish, that's the widest net you can catch, and like that's what you're going to bring in. But then, if you were really looking for that specific thing, the net approach might miss it. You might need to spearfish for those questions. And I fully agree. So for some of those, and those, knowing when and what those key questions asks really depends on how the patient is presenting. So, for example, if someone is telling me like, "Oh my gosh, like I have all this terrible stiffness, and I have these episodes of spasms that are just killing me," um, one question that I ask in those contexts is, well, tell me, are you more easily surprised than you used to be when this started? And people will often like, why do you ask that? Like they'll have this quizzical look on their face, and they're like, yeah, I do. I am a bit more easily startled. Why did you? And they're like, okay, and that can be a very helpful question to ask in something like a stiff person spectrum disorder, where their startle is increased. The spasms can be triggered by startle as well. I had a patient where they actually had a stiff limb syndrome. And if I brought my hand to the affected limb, not even touching them, it would trigger the startle.
That's fascinating.
So not even a tactile stimulus, just like the possibility of a tactile stimulus. And that they were fully aware, they were watching me do it as I was moving towards it. Not even that much of a startle.
Yeah, very interesting.
So asking a pointed question like that can be helpful. In somebody who has a subacute cognitive decline, for example, in those cases, I think it's a very easy question to ask about facial-brachial dystonic seizures. And so the way I ask that is like, have you ever had episodes where your arm and the corner of your mouth sort of come together almost, and I acted out for them because, if a picture is worth 1,000 words, then actually acting it out is worth even more. And I often ask patients, like, if there's a funny movement that occurs, like, can you act that out? Tell me show me what that looks like. And then they can perfectly act out what I might have been picturing in my head, and like, okay, yeah, that's it. Okay. Asking, and that's a great question for LGI1 specifically. Another thing for LGI1 are asking about brief dizziness spells, which can occur, which are thought to be seizures, but we're still not exactly sure. But essentially, it's these like 5 to 10-second episodes of, people have described them as like a chill or a vertigo or a dizziness. And, they can happen with low frequency to begin with, but then as time moves forward, they can start to happen weekly, then daily, then multiple times a day. And that is also a nice clue for the possibility of an LGI1. If you're wondering about MS, something you could ask about is, are your symptoms worse in a hot shower, or if you've been exercising a lot? And that's asking about, the Uthoff phenomenon. So these are knowing the specific questions that, if you have a list of diagnoses already in mind that might fit the clinical syndrome, ask about those specific things. That can be quite helpful.
Right. And that's, as you said, the challenging part with neuroimmunology is that it theoretically could affect any part of the neuroaxis from the brain to the muscles. And so you kind of have to have your algorithm for each potential complaint locked and loaded before you even go into the room.
Yeah, exactly. Like, you having an idea of the syndrome that you're dealing with, and then trying to ask those questions. And like having that knowledge already in store, because there are some things that are very easily up to dateable or Googleable. But knowing a disease and exactly how it presents in the story of that disease, that's not something that you can just a quick search generally accomplishes.
And I'll speak, not to throw any shade at the writers for up to date, but I do find the neurology up to date articles for a lot of topics are not up to date, if you will. And I think to speak to that, right? Like, neuroimmunology is one of the biggest culprits, where the rate of new knowledge is just moving at such a breakneck pace that it's almost impossible to keep like a compendium like that current.
Exactly. Yeah, it's one of the fastest moving fields, and it makes it really exciting, but also takes work to stay up to date.
Right. Now, in the outpatient setting, is there anything that, any chief complaint that perhaps represents the lion's share of referrals, or is it a pretty varied spectrum as far as what you've anecdotally observed?
Oh my gosh, it's such a varied spectrum, because people get referred to neuroimmunology for a wide variety of reasons. Some are due to like an initial workup that revealed something inflammatory appearing. So one example is a meningitis seen on MRI, where you have either leptomeningeal or pachymeningeal enhancement. And so then say, oh my God, they have a pachymeningitis, send them to neuroimmuno. And many times those are actually just chronic CSF leaks. But we, depending on the story or lack thereof for a chronic CSF leak, we'll do the investigations and find that everything is bland. There's no history that's suggestive by like prior autoimmune history or family history or anything of that nature. And then, oh, they have a history of Meniere's. Okay. And CSF leaks and Meniere's can go hand in hand. So then it's just like, okay, it's a CSF leak and we can try and treat that.
Nice.
Then there's other people who come in because of funny spots in their brain on MRI, which may or may not be related to their symptoms. Whole variety of things, and like numbness and tingling in the setting of a recent cancer diagnosis. For example, could this be paraneoplastic, or could this be some sort of inflammatory something related to a myeloma and the high, M spike, for example? So all sorts of reasons people can be referred.
So I think you bring up two populations that are, frustrating, let's say, to the general neurologist to approach. And that is the so-called unidentified, or poorly defined, the UBO, the unidentified bright object on MRI, right? Someone with a bright T2 flare lesion that maybe it's demyelinating. There's one spot, it's not enhancing. There's no clinical thing. Maybe they got that for like a headache workup or something like that. And they're like, how far down the rabbit trail do I need to run for investigating for something like multiple sclerosis or things like that?
Yep.
So in your practice, let's start with someone with that vagueness of a complaint. How would you deal with that kind of setting?
Great question. So just to make sure I got it. So somebody with these T2 hyperintensities on brain MRI discovered due to some maybe potentially or initially sounding vague symptoms. Yeah. So then what I do in evaluating this patient is first off, who is the patient? Are they an 80-year-old male with history of high blood pressure, diabetes, and hyperlipidemia? Are they a young woman with no significant past medical history, and maybe they don't even get headaches at all? So I sort of just go down like, okay, well, what could these be in neuroimmunology? Could these be indicative of MS? So then I ask, like, okay, have you had episodes that could be significant for MS, like a patch of numbness or tingling that lasted several days to a week? Have you had optic neuritis? Or, I ask about the optic neuritis symptoms of like painful eye movements with vision loss. I ask about new onset constipation or urinary frequency and urgency. And one thing I want to say is that I feel like in seeing people ask about urinary symptoms, are you peeing a lot? No, I'm not peeing a lot. And then you get to it, and it's like, oh, you're peeing every 2 hours? Yeah, it's better than peeing every hour. So like the way I ask about it is, okay, when you feel like you need to pee, are you able to hold your urine for like 30 minutes to an hour, or are you racing to the bathroom? Or are you very like cognizant of like your urinary habits? And that has gotten me a lot farther than a more broad question, because then I'll have people say, "Oh my gosh, yeah, if I don't get to a bathroom within 5 minutes, like I worry I could pee my pants," or like, yeah, I really have to pee like every 3 hours, otherwise like bad things will happen. So that has gotten me a lot. And then like for bowel movements, for example, I had a patient who had new onset constipation for no apparent reason. They were a healthy person, and they were even hospitalized for this new constipation that came out of nowhere. Wow. And it turned out that after everything was said and done, that it was due to a demyelinating lesion in the spinal cord that had yet to be discovered.
That would not have been top of my list.
No, not at all. But but that's just part of the assessment. So then after like numbness, tingling, weakness, stiffness in the legs, the exercise, has your workout routines gotten harder for any reason? Are you lifting less weights? Are you not able to squat as much? These can be for like if they're active, like that's so helpful, because that sort of high level of activity will be a much more sensitive marker than for someone who is sedentary and like, yeah, I walk up a flight of stairs every now and then. You might not notice the decrements happening until they are quite severe. So then I also take into account like key past medical history questions that, again, Epic is, or the medical record can be a minefield of chartomas or a dearth of information.
Chartomas. That's a new one for me. I'm going to keep that one in mind.
Oh yeah, I can't claim ownership of that. I had heard that somewhere years ago, but you can ask about history of for MS, for example, infectious mono, big one. I have significantly raised my own suspicion for MS in someone who is otherwise asymptomatic at the moment due to their history of infectious mono and an asymmetric reflex or two. And lo and behold, it was MS. Because it's the highest risk factor, acquired risk factor, I'll say, for MS. But if you're not thinking about MS in particular, and you're wondering about, neuroimmunology, rheumatology, not otherwise specified, then you can ask a whole host of questions that wouldn't come up in a usual general neurology visit for migraine, let's say. So you could ask about, things such as, do you have any new rashes? Do you have any new joint pains? And they might say no. They might say like, yeah, I have this like weird lacy rash that's been on my thighs that just won't go away, and it's new. And they're wearing pants and jeans, and so you're not going to be able to see that right away. But a levato or livedoid rash can sometimes be a symptom of something like a vasculitis. It can be seen in intravascular lymphoma, all sorts of, not exactly neuroimmunology, but, on the rare zebra spectrum of things. So asking about those things, asking about history of uveitis, because many rheumatologic disorders can present with either an anterior or a posterior or pan uveitis. Even MS, for intermediate uveitis, that can be seen in MS sometimes. Oral or genital ulcers can be seen in things like Behçet's or lupus, at least for the oral versions. Constitutional symptoms, fevers, chills, night sweats that drench the clothing or the bed, unexplained weight loss. I've had a patient with a presumed inflammatory myopathy who had lost almost 100 pounds over the past several years, and cancer workup was completely negative, and it was presumed due to an underlying undifferentiated connective tissue disorder, and seems to be doing better with some immunotherapy. And then other things that can cause the immune system to act a little haywire. History of HIV. I've seen there's some thought that the HIV can lead to disimmune problems, for example. We've seen a patient who had in their past the age of 65, new onset of tumefactive demyelination, relapsing, remitting. A biopsy was even done to make sure it wasn't something strange like PML or something otherwise, and just demyelinating. Looked just like what you'd see in MS, and but they had well-controlled HIV for decades, and we presume that this was a disimmune problem related to the HIV leading to demyelinating lesions. And then for like autoimmune encephalitides of many stripes, a history of herpetic infections, neurologic or systemic. So HSV encephalitis, if you see a recurrent encephalitis, be thinking NMDA, not a recurrence of their HSV encephalitis, assuming it was properly treated. But even systemic infections of like HHV6, for example, have been associated with, rarely with autoimmune encephalitis. For things like GBS or other neuropathies, history of infection in the last 2 to 6 weeks, that can be indicative or raise a suspicion. And then, of course, like current cancer or a tumor that looks a lot like cancer, or history of smoking paired with constitutional symptoms. These all can be concerning for maybe there's a paraneoplastic problem going on. Oh, and one other thing, frequent infections. Yeah, so common variable immunodeficiency or other immunodeficiencies can create this seeming paradox of someone who has an immune system that doesn't seem to work and they get lots of infections, but then at the same time can bounce right back to them and cause autoimmune problems.
Fascinating. Yeah. That is one, like, again, like you were mentioning, that disimmune sort of thing, where it's not necessarily just we call things deficiencies, but it's not quite accurate 100% of the way.
Yeah, like a good syndrome, for example, is another good example of of this, where there is both an immunodeficiency as well as a problem of autoimmunity in some cases.
Now, something that kind of came to mind while you were talking about like these historical questions, like the classic systemic rheumatologic disease symptoms, right? Dry eyes, dry mouth,
all that,
all the rashes, all that kind of stuff. And that always, to me, brings up a bit of a conundrum, right? Because we're talking about neuroimmunologic syndromes, but it may not be in isolation. So when you see like perhaps a more systemic autoimmune condition, like let's say lupus or rheumatoid arthritis or any of the other 100 other things that are out there, does that raise your antenna for a concurrent like neurologic manifestation of that same syndrome or a separate autoimmune condition that is just comorbid with the other previous diagnosis?
So just to make sure I understand, if you have a patient who has a known systemic autoimmune disease, and then you have a new neurologic symptom, is that related to the systemic autoimmune disease, or is it just another one that they have also affecting their brain?
Like an example, I think I saw a case report or series recently. It was like people who have like a diagnosis of systemic lupus, and then they get diagnosed with neuromyelitis optica spectrum disorder with like the positive aquaporin 4. Is that lupus still, or is it lupus and NMO?
If they have a positive NMO antibody, then that's NMO. Right. It's just some people think that all the many cases of like lupus myelitis diagnosed in the past, maybe those were just NMO before we had the antibody. So I think that's more of an example of autoimmune diseases grouping together rather than it all being under one autoimmune disease. And the other thing is that sometimes, patient will come in for a symptom and it might be as simple as like really, really bad migraines. And in the course of just my like review of systems, I'll be like, yep, I got dry eyes and yep, I got ulcers in my mouth. And I'm like, oh, and then I ask more because my interest is piqued now. Right. And they'll have like something like Sjogren's or Behçet's or something like that. And they're like, oh my God, are my headaches because of this? I'm like, well, because of would be strong, related to maybe, but it's not like you have neuro-Behçet's, for example, or like a meningitis, for example. You have a systemic autoimmune disease, and that might be playing a role in your terrible migraines, but at the end of the day, they're just terrible migraines, and we will treat them as such. And maybe if your rheumatologist is treating your systemic autoimmune disease, maybe that could help potentially. But yeah, so we see neurologic problems in the patient with a systemic autoimmune issue, and they have nothing. They have it's not a neuroimmunological issue per se. I'll say that.
I'm going to ask you a loaded question.
Okay.
Now this is anecdotal, just to the places I've practiced myself, but it seems that a lot of times I'll have neuroimmunologists are not a dime a dozen across the country. So a lot of times I'll be trying to work in conjunction with a rheumatologist. And it seems like if it's not a systemic rheumatologic disorder, that they don't necessarily have a huge amount of interest in becoming involved in the management of these patients. And I was just curious, is that because it is neurology and no one except neurologists like neurology, or is it something else that I'm missing?
I think that I can't speak to what the rheumatologists that you've encountered are thinking, but I have noticed this as well, where if it's not a systemic rheumatologic disorder, then it's like, well, I'm not sure what to do with this.
Mhm.
Like, for example, trying to treat somebody with autoimmune encephalitis and partnering with a rheumatologist, I don't think that the rheumatologist would feel comfortable doing that, even though we use the steroids and things that they would probably be the treatments they would be very comfortable with. But in terms of what it is, I don't think that they received the training, and thus in that specific thing, and thus they would logically not feel comfortable with that.
Yeah.
I think that if it is a neurorheumatologic issue where they have a systemic rheum issue and they have a neurological issue, so Sjogren's ganglionopathy, for example, or lupus cerebritis or something of that nature, then I think they would feel much more comfortable treating that. But if it doesn't fit sort of the main things that they are used to seeing or have the training for, I think there would be logically less of an appetite. That would be my guess.
That's fair. I remember I had a case with a good friend of mine who's a rheumatologist. She had an extensive transverse myelitis. It was probably like 7 or 8 segments long. And, everything came back negative. Even the LP just had elevated protein, kind of mild lymphocytic pleocytosis, nothing knocking your socks off. And the only thing that came back positive was a double-stranded DNA. But she didn't have any systemic signs or symptoms. I'm like,
yep.
Is this something? And he was like, I don't think. And he was like, I don't think it's something. And I was like, I'm going to give her steroids anyway. And he's like, okay.
And what did you say the symptom was?
She came in. She had really bad lower extremity weakness and numbness. So it was a classic transverse myelitis.
Oh, yeah, the myelitis. Yeah, in that case, yeah. I mean, yeah, that would be concerning. Similarly, I had a patient who, when I was a resident, they had come with subacute cognitive decline, and at first we were like, oh, it's a UTI. Oh, wait, we treated the UTI, but now they have C. diff. Oh, shoot. Okay, well, they're still confused, but this makes sense. It's all toxic metabolic, right? And then our attending rightly was like, wait, they've been on antibiotics for a week now and they're still not better? Okay, no. And so then we did a lot more workup, and all that came back was a sky-high ANA and a sky-high dsDNA. And MRI brain normal, CSF normal, EEG, non-specific. And we're like, lupus? No constitutional anything at all. Nothing else that would have met criteria for lupus. And a rheumatologist, we consulted rheum, and they were interested, but they were like, it's hard to call this lupus, but we're going to treat them like lupus, and got better with steroids and rituximab. So yeah, we see stuff like that.
Yeah, that's why no one likes neuroimmunology.
That's why I love neuroimmuno. It's so cool. It's like, what is this? What's going on? And they got better with treating with their immunosuppressive medications. It's a field so ripe for discovery. It's a field ripe with excitement and wonder. Yeah, everyone should be.
It's very funny you say that, because I mean it is exciting. It's like, hey, maybe we can do something to fix this, and that'd be great for everybody. And I think a lot of it is a little bit of the holdover from kind of the old guard of neurology. I remember one of my MS attendings in residency saying that neurologists are weenies, end quote. And she was talking specifically about giving these more robust chemotherapeutic agents, robust being relative, right? Like rituximab or cyclophosphamide or things like that, right? It's like, because she was retired military. So she would say, sometimes you just have to put on your big boy pants and make a decision. And, I've tried to embody that spirit even sometimes when I was like, oh, I think this is the right thing to do. And, there's not a lot of good evidence sometimes in some of these situations, but it's like, well, mechanistically, I got to take a page from our critical care colleagues. It's like, well, physiologically, this should make sense. And, just cross your fingers and pray for the best.
I mean, there's so much yet to be discovered in neuroimmunology. I think we've come a long way, but there's so many cases where it's like we don't have an antibody for this. We don't have a test for this. The way this is acting, the way this looks on MRI, the way that your symptoms are worsening, like, yeah, we should do steroids because we've looked at, it's not a metabolic thing. We've checked the labs reasonable to check. We don't think this fits the profile of like something else neurodegenerative or vascular or something like that. And so then we just have to empirically treat. Anyone who's treated someone for a seronegative autoimmune encephalitis can know that internal tension of how sure am I this is an autoimmune encephalitis? How sure am I about my history in getting this like 3-month subacute decline? What about that? Well, maybe this started actually a few years ago with this symptom, or maybe that was just their depression, or like I've played this game with myself, like trying to make sure that I feel as comfortable as possible with the history that I've gotten. And sometimes, you do the MRI, you do the lumbar puncture, you check your amyloid to make sure it wasn't like some sort of neurodegenerative thing, at least commonly. And if you're not coming up with things that would reasonably fit otherwise, and if you look at the Grouse 2016 criteria for a possible seronegative, a possible autoimmune encephalitis, and it's lining up not so bad, a trial of 6 weeks of steroids, it could, if it gets better, well worth it. And if it doesn't, well, you got IVIG, you can try too. And if it doesn't work, then maybe it's not immunoresponsive. But sometimes the diagnosis is in the treatment, which we don't like, but sometimes that's what we have, and sometimes it works.
Very true. I find, in the epilepsy world as well, I find myself doing that. It's like, well, you're having these recurrent spells, your EEGs have been normal, but we haven't caught a spell. So here's some Keppra. Let's see how things go over the next 4 weeks.
Yep. Yeah, definitely have done that too. And that has worked sometimes, and it's great.
Sometimes I remember one of my fellowship instructors, and he would say, like, it is just so humbling because you are just wrong so often. Like your initial gut check is wrong so often. You just have to, it's like, well, this doesn't fit that, but I'm not gonna anchor on this too hard just yet.
Yeah. And so just to for another story of empiric treatment, we published a case of somebody who had presented with hallucinations, altered mental status and personality, and hemichorea. And it was onset was like a week or so, and MRI was normal, labs were normal, CSF normal, everything normal. So it wasn't like a stroke or hyperglycemia or antiphospholipid syndrome or anything like that. It was seronegative something, and treated with IVIG, chorea melted away.
Very cool.
And it was one of those rare cases of a seronegative autoimmune movement disorder, and it was relapsing. So I think it was, what we said, 3 to 5 months of no immunotherapy, then it would come right back. And so mycophenolate then evened things out. But yeah, that was a case where no test was ever going to give you the answer. And sometimes you have to treat. Now, when it comes to treating things with like cyclophosphamide, for example, or rituximab, you try to be much more certain because those carry higher risk than once weekly pulse dose steroids. But I've run into some cases where of recurrent stroke, where we try to treat with all the things usual to treat stroke at maximal medical therapy, and they keep having TIAs, they keep having infarcts, and we've done all the work up there we can think of to try and make ourselves more sure about a vasculitis first. But sometimes there are no good biopsy sites. Sometimes there are no great places to even think about a biopsy, or like there's nothing on the MRI that is biopsyable. And we had a case where we treated with cyclophosphamide once monthly for 6 months, and no more strokes, no more TIAs.
Man, yeah, that's a tough case.
So, yeah, and I was nervous about treating with that, but it was what we needed to do.
Right.
And I, made sure everyone was on the same page, and it worked. So again, few and far between,
Right.
but there are those cases where you need to do that.
Yeah.
So having the courage to treat, but then there are also the cases where you must have the courage not to treat as well.
So from a kind of practical, I know people are going to wonder, because I'm wondering myself. So if you are seeing someone who you're thinking has like maybe a subacute, autoimmune encephalitis or something like that, that subacute cognitive decline, what's your steroid dosing regimen look like for that period of time?
Oh yeah. So if they meet criteria for autoimmune encephalitis and you've done your workup with like making sure it's nothing metabolic, making sure that you've got an MRI, CSF, and for CSF, I don't just use the basics plus the Mayo autoimmune panel, but I also check for oligoclonal bands, IgG index, beta 2 microglobulin, which is a lymphocyte turnover marker, because those can be sort of secondary measures of inflammation. And I've definitely seen those cases where CSF is completely bland. But like the IgG index could be elevated, and that's helpful. But for steroid treatment, this is based off of Mayo's structured steroid protocol, where they use 1 gram of solumedrol for 3 days in a row, and then they do once weekly for 6 to 12 weeks. 12 for like the cases that have seizures, 6 for those that don't, and you reassess for treatment response. And if there's not been a response, then you can go to using IVIG. And if there's no response with that, and these are in the seronegative cases specifically, if you have an antibody, that helps guide your treatment. So yeah, especially, and if it's that's like for the all-comer, in general, like first-line treatments for autoimmune encephalitis. In the cases of a like high risk antibody for something like high risk for cancer antibody. So these would be like your ANA1, anti-Yo, where if you see the antibody even without any neurological symptom, you're still looking for the cancer. Right. Amphiphysin, if that's causing an encephalitis, then like steroids, cyclophosphamide, get rid of the cancer. And the reason for jumping to cyclophosphamide in those cases is because these are generally T-cell mediated diseases, and your steroids are going to help with that. Your IVIG probably not, and as much. And then rituximab doesn't really touch your T cells, so cyclophosphamide does. So yeah, and the ataxia cases too. Like if you have an autoimmune cereballitis, those are often T-cell mediated disorders, and that's where you're reaching earlier for the cyclophosphamide as well.
Gotcha. That makes sense.
Yeah.
So one last clinical conundrum I would like. When you get a referral from a general neurologist, let's say, who is like patient with, let's just say, X vague symptom, they get a Mayo perineoplastic panel, and you get this weak positivity to some antibody. I had to ask. I was like, I'm going to send you to I'm going to send you to an expert.
Yep.
Let's send you to the neuroimmunology guys down the hallway here. And what do you guys do with that? Other than, I assume, lots of counseling.
Well, yes, a lot of counseling. So we do see cases of like, I think the GAD65 is the neurologist's ANA.
Yeah, it's turning into it.
Yeah. So for low levels of GAD65 antibody, first, do you have symptoms like that would be relevant to a GAD65 antibody? So those things would be like stiff person syndrome, an autoimmune encephalitis, seizures, things of that nature. And if they do not, then I counsel that this is not an antibody that is relevant neurologically, likely. Some people think that it can be a marker of like tendency to inflammation. So because GAD65 autoantibodies are seen in type 1 diabetes, and sometimes that can exist before the type 1 diabetes starts. And so if you have like the diabetic phenotype and you got the GAD65 antibodies, and that's type 1 diabetes, whatever the level. But if it's like for stiff persons at least, like a neurological level. So depending on if you're using a radioimmune assay versus enzyme immunoassay, your level cutoffs vary. But there are published cutoffs there that should raise or lower your suspicion. Then you start to get more concerned about something like a stiff person's, and then go from there. But I've also seen like very weak positivity to something like a voltage-gated calcium channel autoantibody, for example, and completely normal autonomic function. Their muscle strength is fine. There's no fatigability. And then I say something similar. I was like, you might have a tendency to autoimmunity. And if they have another autoimmune disorder, but they have zero symptoms of, whatever the antibody is generally associated with, and it might be just like a
cross reactivity or something.
Your immune syndrome, like kicking off something else. I mean, there's definitely, like, for example, in lupus, like you can have some positive rheumatoid factor, positive Sjogren's, and it's not that they have Sjogren's necessarily, but they might just be tagalongs. We see tagalong antibodies not infrequently, like GFAP antibodies, for example. If you see a GFAP antibody in the setting of NMO or NMDA, they probably have NMDA and NMO, not a GFAP astrocytopathy. So I think just putting the antibody into the clinical context is the important thing.
I think that is somewhere we're probably lagging behind the rheumatology folks, is like putting our pretest probabilities into a better perspective as far as like, what does it mean if it comes back, weakly positive, strongly positive? Does it match the clinical phenotype, right? Because we've definitely seen, I've had patients who, they have like an RF factor, like 200, 300, 400, whatever, but they have no joint pain, they have no stiffness, blah, blah, blah. So there's nothing clinically there. And so they're like, well, you don't have RA, and I'm like, oh, okay. I think we're probably heading in that direction as we start seeing these panels getting ordered more and more often for more and more vague complaints.
Yep, absolutely.
Any final thoughts or clinical pearls that you think the trainee out there should be aware of, whether they're neurology, internal medicine, what have you, that should raise? I know we've talked about a lot of things already, but the biggest takeaway for you from this discussion would be what? If you could have our folks learn one thing from our conversation today.
Oh my gosh, you're limiting me to just one thing. Okay.
1 to 3.
1 to 3. Okay. I think, let me think about that. So I think one point is making sure that if the syndrome and the symptoms could fit with a rheumatologic disease or a neuroimmunologic disorder, make sure that you are asking specific questions for those disorders. So if you're worried about something like a vasculitis, don't just ask about stroke symptoms. Ask about systemic symptoms like, coughing up blood, sinus issues, peeing blood, rashes, things like that. So asking those in your HPI and review of systems. Similarly, getting a really good family history, and not just, do you have any family history of autoimmune disease? No one knows what that means, or very few people do.
Right.
Like, do you have a family history of psoriasis, celiac, lupus, rheumatoid arthritis, inflammatory bowel disease? Just list them. And you will sometimes be surprised by the answers you receive. So I think I'm going to lump that as one.
That's fair. That's fair.
2, really dive in to the onset and the pacing of the symptoms and make sure that you have that as down pat as possible. So that's a number 2. And do I have a third one as a catch-all for our discussions? I will just say, be curious. And that applies to both interacting with your patients as well as reading more and familiarizing yourself with the wondrous world of neuroimmunology.
That's a great point. God, I probably said it today. I just finished rounding a few hours ago, and probably at least a handful of times I had to say, "What do you mean by that?" In response to something the patient had just told me. It's like, could you tell me more about that? And it is that,
exactly.
that funny thing of language where they know exactly what they mean, but I don't. So I need them to break it down for me.
Yep. Tell me more about that is my favorite open-ended question. That is one of the most useful open-ended questions in my experience.
It's just like, I don't know. There's something satisfying. It's like you finally have heard something in the history. It's like triggered a pathway for you to go down. It's like, maybe I can figure out what's going on here, right? It's the lifeline for me to try and solve this puzzle.
Yes, it's the clearing in the forest.
Absolutely. Well, thank you so much for taking the time and talking with us. We'll definitely have to have you back on and talk about more specific neuroimmunologic disorders in the future, schedule permitting.
Yes, I would love to do that. Thank you so much for having me.
And if people want to find your work, where should they track you down online?
So I do have a Twitter/X account. It's just at Denis Balaban MD. I will say that I do not post as frequently as I once did, but I have that account. Let's see. I mean, I have my MGH website that people can look me up as well. But yeah, and then PubMed, I suppose.
There you go. A real researcher, not like me. So
I'm slowly getting more publications to my name, but
right.
there are certainly
you got many years ahead.
Far
of you.
more published than I.
So thank you so much, and as always, you can always find me also on Twix. I've heard people call it Twix. I kind of like that. It's a little bit better than X, I think. But
Twix. I do like that, though. I think the candy bar company may have words about that.
True. There's probably copyrights there. But I'm at Dr. Kentris, DrKentris, and you can of course find all of our past stuff on the website at theneurotransmitters.com. Denis, thank you again so much. Really appreciate you taking the time.
Thank you so much for having me. This was a treat.
Likewise.